All right, everybody, I want to welcome you all to our fourth webinar of the year. We are very excited and coming to you live from our Spine and Sports Service Center. We are here with some of our fantastic PT and PTA students who are currently with us on their clinical rotations. We are very fortunate to have two fantastic guest speakers with us today who are going to talk about vestibular therapy. Without going into too much detail, I am very excited to introduce Dr. Katie Bell and Dr. Will Bernaldo, who are our very good friends from Empower Neuro Rehab. We are very fortunate to have them with us today. I know that some of our students are very familiar with them based on their academic work. So again, we are very fortunate to have them share their expertise with us. And with that, I'm going to turn it over to.
All right. Hi, everyone. So we're presenting on vestibular therapy. We're going to start out with a brief, why should you listen to us is what I titled this slide. So we'll start with Will here.
So hi, I see some familiar faces in the crowd. I got to say hello to a few of you. So I am a physical therapist, doctor of physical therapy, got my degree at University of St. Augustine. I have taught there essentially since pretty recently after I graduated, and then have taught in several other locations as well, including Hawaii Pacific and West Coast University. I did torture myself by getting my NCS. I highly recommend it for any of you. Sounds like I heard some conversations about you getting getting through your board exams. If you feel like that wasn't hard enough and you want to do something worse, definitely get your clinical specialization. I do recommend it, but it's a challenge. I did my clinical internship in vestibular rehab at Balboa Naval Medical Center. Really, really amazing facility that they have there in their brain injury unit. And so they have, because brain injury and vestibular issues, as we'll talk about, are so commonly associated, they have a whole unit dedicated to vestibular pathology. So pretty fun. I got to do a lot of cool things over there. And I talked about teaching stuff. So I guess that's why you should listen to me.
Okay, and my name is Katie. I also teach at St. Augustine, but I'm an OT, so I teach clinical neuroscience to the OT students. So I have a CBIST, which means I'm a certified brain injury specialist trainer. I became a provisional certified brain injury specialist when I was still a student, actually, and then transitioned to CBIS and CBIST. So I treat patients with vestibular disorders, and specifically I treat all the pediatric vestibular referrals we get. I do see some of the adults as well, but I see all of the needs that we get. Similar, pretty much the same evaluation and intervention, just sometimes you have to be a little more goofy and put stickers on your nose and stuff, but all the concepts are the same. Okay, so objectives, we're hoping that you'll walk away today with basically some of this. Hopefully it should be a recap if you've paid attention in your neuro course.
Some of them haven't had it yet.
Oh, okay, surprise, you're getting ahead.
Yeah.
Okay, so we're going to go over the anatomy and physiology of the vestibular system. Then we're going to talk about the signs and symptoms you might see for someone with a vestibular disorder. We're going to look at some of the different diagnostic tests for how you can kind of triage what's going on with that patient. And then talk about the appropriate course of treatment based on what you find with that assessment. So we're doing like a crash course in this to fit it in an hour and a half. I did like a 14-hour training on this. So, you know, the notes are here for a resource. You've got the slides, and then just know that, you know, we're kind of going surface level, but we're happy to dive in with questions if you have them. So we're starting out with basically the basic anatomy of the vestibular system, and it's primarily your inner ear, right? So you've got these otolith organs. We've got a utricle and a saccule, and we're going to go over those on another slide, so I won't harp on them here. The semicircular canals, you have 3 in each ear. So they're shown here. These are these tube shapes. They all sit perpendicular to one another so that they can detect motion in different planes of movement. Then you've got your vestibulocochlear nerve. That's one of your cranial nerves, which is coming out here and heading into your brain. And then kind of, I separated it out over here. You have a cochlea as well. I'm including it because it's in all the images, right? It's the big snail-shaped structure there. That's responsible for your hearing, not really your vestibular system, but it's all connected and intertwined, right? So looking at the vasculature that is supplying the
Sorry, I'm looking at some of my neuroscience folks.
So looking at some of the blood vessels and blood flow that supports the vestibular system, we've got several different blood vessels here. And of course, if you have damage to any of these blood vessels and these areas of loose blood supply, they're going to be damaged. So it's something we want to consider when we're looking at what might be causing some sort of vestibular symptoms. So the anterior vestibular artery is supplying the anterior canal, the horizontal canal, the utricle, and then part of the saccule. The posterior vestibular artery is supplying the posterior canal, the saccule, and part of the utricle. So keeping in mind damage to these blood vessels, or really anything leading up to them, right, can cause problems with the vestibular system. Okay, so the vestibular system, like I alluded to earlier, it's innervated by cranial nerve 8. And let's see, what else do we want to say on here? Okay, so the vestibular cochlear nerve has a couple different branches that we're going to talk about. The superior vestibular nerve innervates the anterior canal, horizontal canal, and utricle, whereas the inferior vestibular nerve innervates the posterior canal and the saccule. Oh, look at that. I didn't know I had an animation on here. Surprise. Maybe that's why I'm so confused about the notes here. Okay, and then it does have a third branch to it, which is the cochlear nerve. It goes to the cochlea for hearing. We're not going to talk about that. All right, so then getting into these semicircular canals, because these are some of the big players when we're thinking about vestibular problems. So each of those canals is filled with a fluid. It's called endolymph. And at the end of each of the canals is this enlarged portion called the ampulla. And inside the ampulla are hair cells. And when we move our head, the fluid is kind of sloshing around and it's pushing and pulling those hair cells. And the movement of those hair cells is what's actually signaling via the vestibular cochlear nerve to our brain about where our head is moving, how quickly it's moving, in what plane it's moving in. So you've got, again, 3 canals in each ear. You have an anterior canal. That is the one in yellow here. That is kind of straight up and down. And that's going to detect up and down movement. So if you're nodding your head yes and no, that's being picked up by the anterior canal. The posterior canal, which is this red one in the back there, is detecting lateral tilt. So if you put your ear to your shoulder, that's getting picked up at the posterior canal. The horizontal canal, which is the blue one here, that is picking up side-to-side movement. So if you shake your head no, that is being detected by the horizontal canal. Any variation or any combination of movements is going to be picked up by multiple canals. And then we've got the otolith organs. So these are specialized areas within the inner ear that detect linear movement. So the semicircular canals are detecting angular acceleration of our movement in space. These are detecting linear movement. Specifically, the utricle is sensing horizontal acceleration and deceleration. So like if you're in a car and you suddenly step on the gas and it goes forward quickly, or you brake quickly, you can feel that movement. That's being picked up in the utricle. The saccule is vertical acceleration. So that's something like going up and down in an elevator when you can feel that up and down movement. That's via the saccule. Inside, we've got this more hair cells, and they're sitting in this gelatinous layer. It's almost like a layer of jello. And you've got sitting on top of that these little otoconia. They're these little crystals that sit on top of it. And because they're kind of heavy and they're sitting on top of this gelatinous layer, when you move in one of these directions, gravity is going to pull them And when they start moving, they're gonna pull on the layer of I was gonna say jello, gelatinous layer. And when they do that, they're gonna cause the hair cells to tilt as well. So once again, the hair cells are providing input on where your head is and where you're moving in space. Okay, so when we talk about vestibular disorders, we also think about them in terms of central dysfunction versus peripheral dysfunction. So peripheral dysfunction is everything out here. It's in these semicircular canals or the utricle, the sacral. It's before we get into the vestibulocochlear nerve. At that point, from the nerve all the way into the brain and all of these different structures that are involved in the vestibular system, those are considered, if there's a problem at that end, that's considered to be a central dysfunction. If it's out here in the semicircular canals, that's going to be a peripheral dysfunction of the vestibular system.
All right, so we'll pause now for a quick evaluation. Just make sure you guys got all of that. So there should be a test at the back of the handout. No, I'm just kidding. Okay, so that's a lot, right? The purpose of that is basically just to expose you to this point, right? So you should have a brief understanding of where we're talking about in the brain and adjacent to the brain and kind of what things do, okay? And then we'll talk about how certain problems can arise when each of those parts can get impaired. So assessing and treating vestibular conditions, this is what we love to do the most in the clinic. Well, I don't know about the most. It's one of the things we enjoy the most for sure. But as with anything in assessment, your patient history is critical, okay? And with vestibular in particular, by the end of the patient history, you should basically have like a 90% confidence about what's going on with this patient and what's likely the cause of their symptoms. So what kinds of things do we need to know? We need to know about when did this start? So what was happening when it started? Usually it's insidious. It usually just comes on all of a sudden. Sometimes it's after a head trauma, like a concussion, or a more severe brain injury. But even with that, sometimes the symptoms actually don't present until a day or two later. So good to know that initial onset. How often does it happen? So this is going to be critical in terms of diagnosing and treating as well. Does it happen all the time when you do one specific thing? Does it happen randomly? And then how long does it take to go away, right? So that duration is really critical as well. And what are your known symptoms? So again, is it positional? Is it, I have no idea, it just comes out of the blue? So you really want to dig into what's going on for the patient in terms of what causes the symptoms, and then what allows them to have those symptoms go away, or what provides relief. So because patients, and probably, have any of you ever had vertigo, severe vertigo? Okay. So unless you've had severe vertigo, you don't really think about vertigo very often, right? And as a result, we don't really have a good vocabulary for vertigo. And so when patients describe this stuff to you, it's going to be wild. I've heard all kinds of descriptions, right? So this is a fun one that I have in just as an example in my life. So when somebody tells you something really off the wall, make sure you clarify what they mean, right? So kind of dig down into what does that mean for them as best they can describe, right? So when I have, I told my wife once that when I have a fever, I feel like heavy paper. She was like, what in the world are you talking about, right? And it's just this feeling that I had, right? But I had to be able to describe it. I just feel very heavy and like my body is larger, or gravity is heavier or something like that. It was just a sensation that I didn't really have the vocabulary for. So realize that is a really common thing when you're treating vestibular dysfunction, because patients just don't think about it and have the vocabulary to describe it. Comorbidities are really important, right? We talked about the blood flow for a reason. So CVA risk factors, that's going to start me thinking down the line of, okay, could this have been a stroke? Could that be a stroke that caused some kind of dysfunction with one of those small blood vessels that go to our vestibular system? Prior BPPV is predictive, and we'll talk about BPPV if you don't already know what it is, but that's predictive of future BPPV. History of migraine, there's something called a vestibular migraine, right? Which is a subtype of migraine itself. And that can develop from a history of migraine. They had hearing changes. We're starting to think of maybe there was this patient might have Meniere's. So all of these things will send you in different directions. So things that we normally or maybe don't always ask about in our history are critical for this patient population. Vision changes, history of concussion, AFib, etc. Age, gender, family history, all of those can be contributory. So older age, the older we are, the more likely we are to have BPPV specifically, more likely to have a CVA, certainly. The gender, females are more likely than males to get BPPV. We can talk about why that might be. Family history of dizziness is a predictor of BPPV as well. And then impact on occupational performance, obviously. So that's something we want to think about. What is the function that they're missing now because of their symptoms? Okay, so to treat or not to treat? How many of you are studying to be neurologists? Okay. So unless you're a neurologist, we're going to be treating mostly peripheral disorders, okay? The caveat to that is, so there's kind of two directions this can happen in. When I have a patient come into my clinic, almost always the diagnosis, I have a neuro clinic, they had some kind of neurologic problem, right? So if somebody had a stroke and they're coming in for stroke rehab and they have central signs and symptoms, am I really concerned about that, sending them to the ER? No, I know they had a stroke, right? Somebody's coming to you in an orthopedic clinic, for example, and you're evaluating their shoulder and they have central signs and symptoms. Now that's a problem. Now I'm saying you need to go somewhere else for an evaluation. So just because they have central signs and symptoms isn't necessarily something to worry about, right? It depends on what that patient's coming in for and what you already know, okay? And there's some other reasons why central signs and symptoms may not be problematic. But so what we're looking for is a vestibular deficit that is stable and unchanging. What does that mean? So that means that it's not something that the structure that has been affected is not getting better or worse over time. It's that, or specifically worse, right? But that's not changing. So if you have BPPV, the structure is that crystal that's floating around, and that's going to be there until we put it back to where it belongs, right? If you have Meniere's disease, that's a fluctuating disease. So that means, so I don't know if any of you know what Meniere's is. We can talk about it briefly, but that means that it's going to be harder to treat the symptoms because the pathology is not stable, right? So it's as if somebody is continuing to do an exercise that's hurting their shoulder over and over again, right? Until they stop doing that exercise, we can't do treatment. So because that pathology is happening to their body by itself, it's not something that we can necessarily treat. Vestibular neuritis, that's something that's going to come on and go away over time. We typically can do some things with treatment once that's resolved, okay? So those are the types of things that we're trying to determine at bedside. Assessments, cranial nerve exam. All of you should be familiar with a cranial nerve exam. It's really not different for vestibular testing other than what we're looking for, and we'll dive into that a little bit. Head impulse test. So that is a test that we're going to do for, do we have more? We have more, okay. So we'll show you what that looks like. It's for VOR dysfunction. VOR cancellation test, that's a test that we'll use for a central sign. That's a typical central sign. So all of these tests are examples of things that we would use to look for either peripheral or central, right? And that's one of the biggest things that we're trying to determine within that evaluation, is it peripheral or central? So this is our bedside oculomotor exam. And we're just looking for what here? So that's your H pattern test as well. So we're looking for that range of motion. Do they have full range of motion in all directions? If they don't, what am I thinking? Central. It's been a minute for some of you probably. All right, saccades. What's a saccade? Anybody? Any idea? Saccade is basically the word for jumping, all right? So we'll talk about two different types of saccades. There's a corrective saccade, which is a problem, and there's a normal saccade, which is, as it sounds, right? So you should be able to look between two targets, which is what's being demonstrated here. I don't know if any of you recognize this eye model.
You're gonna see me a lot.
Yeah.
in these slides.
He is a great vestibular actress. So when you're jumping between 2 points, so you should be able to do that accurately. So if we see that you miss the target and come back, we call that a corrective saccade. Jumping between 2 points would be a normal thing that you're able to do. So that would be a normal test if you're able to accurately go between two. If you have more than one correction, we would call that an abnormal test. And so I think you demonstrate an abnormal.
Do you want me to, let me see if I can get them to play again. I don't actually know how to do that. Okay, so this one will play again first. He's trying to do smooth pursuits. You'll see that he loses track of the pen and then has to catch up to it. So there's like some movement here, right? Some extra movement. He can't just smoothly follow the pen.
So those are corrective saccades.
And then I'm gonna look to the right first, and those are gonna be normal. And then the left, I'm trying my best to fake a corrective saccade. So it's gonna stop and then start again. So there's two movements instead of one. It should only be one movement. So these are normal, right? Just looking to the side and back. And then it's gonna be like a few steps to get over to the side, right? That's
So
abnormal.
Really good.
It was really something.
Really
to
good
film.
acting right there, actually. Questions on that before we move on? Does that make sense with what's happening? So the first one, you're just having them follow. You want to see smooth eye movement back and forth. The second one, you're having them jump between 2 points. So I'm saying, look at my finger. I usually have my pen light. I say, look at my pen, look at my finger. Look at my pen, look at my finger. They're going between the 2 points. You do that off to the right and off to the left. Catch-up saccades. Okay, so this is our HIT test, head impulse test, or HIT. If you see a positive with this, it's indicative of a vestibular hypofunction. And so we can talk a little bit about what that means, but this is a very nice bedside test. It's one of two tests that we typically do for this specific pathology. So we'll give you a video.
This video, just so you know, it's gonna be in slow-mo, and you're gonna see her lose track of the target and then have to move her eyes back. She's trying to keep her eyes straight ahead. So she was asked to, I'm assuming, probably look at the person's nose the whole time. And when they moved her head passively, she lost the nose and then had to travel her eyes back to it. So that's an abnormal finding. They should be able to keep their eyes on the target, probably your nose, regardless of how you are passively moving their head. Yeah.
Would that be considered like a left hypofunction if they can, depending on which way the head is turned?
Correct. Yeah, so the side that you move their head to, if it's abnormal, it's a positive on that side.
On the left side.
Good question. Yeah. So are any of you familiar with VOR? That means vestibular ocular reflex, right? So if you haven't had this, I know I talked to a couple of students who said they haven't had this course yet, but there's a reflex between the inner ear and the eyes. And it's why we're doing all this ocular testing. So people are like, I'm here for my balance and I think it's in my inner ear, and why are you doing all this testing with my eyes? That's the primary reason. So I always, I know you guys love my wonderful jokes, but I always say that the vestibular system is the window to the soul, and the eyes are the window to the soul and the vestibular system, right? So we can see what's happening with the vestibular system based on what the eyes are doing, and you'll see that as we move forward. Or cancellation. So this is a test. This is a central sign. If they're unable to do it, you ask the patient to stare at a target in front of them. Usually I have them put their arms out in front of them and stare at their thumbs. And you're going to ask them to rotate back and forth. And what they're doing is suppressing their VOR. So the VOR in the last test was being assessed for its accuracy. In this test, you're assessing, can they suppress it? And that's mediated centrally. So if they're unable to do that, meaning their eyes don't stay on the target and they have to catch up, then that's a central sign.
So that's what he's being asked to do. And you can see, again, those corrective saccades. He's having to do these little jumps with his eyes to keep looking at the pen with his head movements. Okay.
This is the most fun assessment that we do in the clinic. Patients love it. It's called dynamic visual acuity. So visual acuity is your ability to see. So if you think about your eye exam, normally you cover one eye and you look at a chart and you read it. That's your static visual acuity, okay? So you think of like your 20/20 or 20/15, 20/30. What we do is we're gonna have the patient read a chart, so similar chart, and then and we're allowing them to use both eyes, and then we're gonna move their head rapidly at a rate of 2 hertz, which means it hurts twice as bad. No, it means 2 cycles per second. So you need to go from here over to here, back to here twice in 1 second. It's pretty quick, right? So that's the rate at which your VOR should fire. That reflex should be at 2 hertz. So we're gonna move their head. Typically, you can have the patient do it themselves, but typically what we see is that they start to slow down once it gets hard, right? And then that's basically a failure of the test. So go ahead and we can show a demo of that. Maybe.
Having tech issues.
So I'll keep talking about it. But so we do the static version first. So we're going to see how low they can read. We don't really care what that number is, but that's your baseline, right? So you can have them, you should have them wear their glasses if they do wear corrective lenses. But you're going to have them go down. Oh,
Sorry.
we're just going to read it now. So you have them read down as low as they can. And then you perform the test again with the head moving. And then you see how far they can go and how close they can get to that static line. Normal is within 2 lines. So if you can get with only 2 lines lost or less, we would consider that a normal test.
Can you hear the metronome?
Good job. So we set the metronome to 240 beats per minute, and that's twice as fast as 2 hertz because we're having it hit at each head turn each side. That makes it easier for the patient to kind of maintain. But again, we typically are going to help the patient do it. So, have any of you seen this before? Cervical joint position error testing?
Question.
Yeah. Oh.
So if somebody missed more than 2 lines, would you say that's indicative of central or peripheral?
Sorry, that's a good question. Yeah, it's a vestibular, it's a VOR dysfunction again. So it's a hypofunction.
Okay.
Yeah. So it's basically the functional version of the head impulse test, right? Because we're seeing that with the VOR, what it does is allow you to focus on an object with head movement, right? And if you can't do that, then your eyes go with you and then you have to correct back to see it. So what you'll see is typically you're going to see a positive hit, and that'll allow you to identify which side is affected. But with this test, you'll see how affected, how impaired they are functionally, essentially. Good question.
Okay, so,
So still me? Yeah.
well, it's not changing off that slide, so it's gonna be you forever.
Okay, great.
I'll talk about it. So
Okay.
cervical joint position error. Sometimes people can have vestibular symptoms, feeling dizzy, because they're getting the wrong signals from their neck about where their head is in space. And when there's a mismatch between the visual input coming in about where you are in space and where your body thinks you are in space, you can experience dizziness. So this is the cervical joint position error test. We've got a target here. Once again, this is me wearing a laser on my head, and you have the patient close their eyes, turn all the way to one side and back, and you're trying to see if they can accurately find the center again. You're gonna have them do it several times in each direction. We're only gonna show it one time in each direction for the sake of time. But you're gonna take a look at wherever they land, so that's not, we're hoping for the yellow or the green. Sometimes we'll see it like completely off the page, but yellow or green would be considered normal.
Yeah, and essentially, we're assessing the overall proprioception of the cervical spine. Questions on that?
You said their eyes were closed?
Mm-hmm.
Correct, yeah. So how accurate can you be with your eyes closed? I've seen, so when I did this at the Naval Hospital, I actually saw, these guys can be pretty competitive. People get to the point where they could go between a target here and out here. We don't have this set up here, but in different directions with their eyes closed and accurately hit the target with their eyes closed back and forth. It's pretty impressive. But that's, you know, your proprioception can be trained very well, right? So we think about, you know, highly trained athletes are really skilled at being able to put their body in certain positions very accurately and very quickly, right? So this is something especially for, I would like to see this more in orthopedic clinics actually, in addition to vestibular. And I think it was initially made for, by Dr. Landell at USC to be used for, we have a Trojan. Believe it or not, we are on opposite sides of the spectrum in Los Angeles. I went to UCLA for undergrad. She went to USC, and we still are able to work together amazingly. Yeah, so he developed this for not only for cervicogenic dizziness, but also to help treat whiplash, right? So because that's a source of chronic pain as well, right? We think about the same thing with like ankle injuries where you need to rehab that positional awareness. Same thing happens with the cervical spine.
Okay, so.
Yay.
We don't have our notes, so I'm just concerned about time. If you touch that, it stops on here.
Oh,
I
sorry.
can't change it on here.
All right, perfect.
So,
Let's talk then. Okay, so BPPV is the most common cause of vertigo, right? Have any of you had BPPV? You said you had vertigo before? No? Any of you seen BPPV? Okay. It's really interesting. The pathophysiology is very simple once you understand kind of the general anatomy. This is the reason why I love vestibular therapy and how I got hooked on it, right? So I'll just tell a quick story. I know we're talking at light speed because this is so much information to get in a short amount of time. But when I was at the Naval Hospital, we had this guy who came in with vertigo. He was on duty in the middle of the Gulf on a boat and suddenly got extremely vertiginous, right? Like, so he couldn't stay upright. He was vomiting, you know, last place you want to be is on a boat. And it was at night, so he couldn't really orient visually. And so long story short, they got him back to shore. They got him to, they had to medevac him out. They sent him to Germany. So at every step along the way, I think before he got to us, had 6 different providers across like 4 or 5 different countries trying to assess and treat what was going on for him. This was a while back, so probably less understanding of BPPV at that stage. But at every stage, they were like, I don't know, we do all of our tests and we can't figure it out and nothing's getting better. So he got to us, me and this other student from USC, unfortunately. Are there any SCE students in here tonight? No, okay. Or this afternoon. So anyway, he got to us and the two of us are looking at each other like, I don't know, this history sounds like it's BPPV, but it's clearly not. We don't know anything. I mean, we've been here for like 2 weeks. And so we'll do our testing and whatever. So we do our testing. It's very clearly positive for BPPV. We do, we're like, okay, well, we think this is what it is. We do our treatment, and then we retest, because that's what you should do. And we lay him back to retest, and he starts crying. We're like, oh my God, what did we do wrong? Like, well, this is not okay. And we're like, what's going on? You okay? And he's like, it's gone. It's gone. And he was like, I thought I'd never be okay. I thought I was going to have to retire from the military. I thought I would never be okay. And so how many treatments do we have that you can fix like that? Very few, right? So BPPV is really fun. So I would say hopefully that inspires you, no matter what setting you're going to be in, that you can at least understand how to figure out that it is BPPV. And if you can't treat it, send it to someone who can, because it's really debilitating, but it's also fairly easy to fix. Okay. All right, so symptoms.
Glad I fixed it.
Oh man,
Okay.
it's not as easy
I
as
don't know, guys,
BPPV to
sorry.
fix the computer. Okay, so symptoms. So typically when somebody has BPPV, the symptoms are really brief. So we're talking
There we go.
about within a few seconds. The episodes will come on and go away. If it's a subset of BPPV called cupulolithiasis or cupulolithiasis, those symptoms will be a little bit delayed and last a little bit longer. But typically we're thinking of seconds to minutes, not minutes to hours or days, right? So that's your first rubric of kind of what do we have going on. If somebody says, I just get these bursts of vertigo and it's when I turn my head like this and then it goes away and I don't know what's going on, right? So we're going to start to think BPPV if that's the case. The affected canal, so we're going to look at, so we showed you that there are 3 canals. You have 3 canals on each side, which means there are 6 possibilities, right? So let's back up. What causes BPPV? You remember those little crystals that we showed you earlier? One of those floats off and then floats into the canal where it shouldn't be, or multiple can do that. And essentially what happens is because fluid shifts to stimulate one side and inhibit the other when you turn your head, when that fluid shifts, typically there's a typical flow to that fluid on each side, and that tells your brain, oh, I've turned my head to the right or I've turned my head to the left. If you've got a crystal on there, it pushes that fluid too quickly on one side, and that tells your brain you're actually spinning. And so your eyes will actually have this rhythmic movement called nystagmus. And so we're going to use that nystagmus to tell us where it is. Okay. So that test that we do, so the typical test that everybody knows when they think about BPPV is the Dix-Hall pipe. Remember that that is one test that assesses 2 canals, but we have 3 canals. And that 3rd canal is the most overlooked canal, right? So typically when we tend to get more of the difficult cases, because if it's corrected by this, usually somebody else figured it out because that's the thing that they remember. But this is a test where you have the patient lie down, you turn their head 45 degrees to the right, you have them extend, and you have them lie down. And then,
video on it.
yeah, we've got a video, and then you're looking for their eyes. Okay. Supine roll. Basically, you're either going to have them turn their head 60 to 90 degrees one direction or roll 60 to 90 degrees. All we care about is the head position, not the body position. And we're looking for nystagmus with that one. So the term geotropic means toward the ground, geo, toward the ground, apo, or ageotropic would be away from the ground. And those will be important for us to talk about.
And the nystagmus is named for the fast phase. When we see videos, you'll see that the eyes kind of quickly move one direction and then kind of float back a little bit. It's all relatively fast, but there's one direction that's faster than the other. That's the direction the nystagmus is named for. So if you do a test and it's we say that the nystagmus is feeding towards the ground, that means it was quickly moving to the ground and then more slowly coming back up. So we're gonna show a loaded Dix Hall pike, once again with me. And so you start with the head turn, 45 degrees, and this is a loaded Dix Hall pike. So this is a relatively new concept that they've done some research on, and they've shown that if you have the patient spend some time in cervical flexion before you actually move them back into extension, it loads the crystals. And then when they go back into extension, you get a more dramatic response. So the nice thing with that is if you're just going, especially if you're just going based on looking at their eyes, they're gonna have more profound symptoms. You're gonna see the nystagmus more clearly than if you're doing a standard Dix Hall pike. So if you've got a recording device, I mean, we have a recording device, you'll see a video from it. We still do it this way because it's just easier to see. So this is the loaded Dix Hall pike. The only difference from the traditional, again, is that time spent in cervical flexion before they go back into extension. Once they get back into extension, you're looking at their eyes to try to see if you're picking up on any nystagmus. Yeah.
Just wondering how much time they should sit in the cervical flexion before.
I think 30 to 60 seconds. Usually I try to keep it at a minimum of 30. I'd say that's a pretty typical
Yeah, at least 30 seconds.
time frame. So depending on what resource you use, people will say to hold the different positional either tests or treatment for about 30 to 60 seconds. My theory is that longer is not going to do any harm. So if you have the time, it's more successful, right? Because you're just letting the debris fall down to the bottom of the canal before you move it to the next spot. So if you have the time, I would say longer is better.
And then this is the test for horizontal canal BPPV. Let me see if I can get it to play.
This is the
Guys,
napping
I
position.
teach virtually every single week and I know how to use PowerPoint, I swear. Here, okay. So supine roll tap, oh my gosh. Oh, now we're just in a whole thing.
So you do want to flex the cervical spine
There we go.
about 20 degrees, and then you're rotating 60 degrees. So either position is fine. So if the patient does not have that amount of cervical rotation, you can just have them go into the sideline. So whatever is comfortable for the patient. Again, we're worried about ear position and more specifically the position of the canal. So we're just trying to put that canal in a provocative position. With horizontal testing, you should see symptoms bilaterally. And so the way that we identify which side is affected is so careful here. When you have geotropic nystagmus, meaning the nystagmus is going toward the ground, that means that you have the crystal is floating, so it's a canalithiasis, and that means that the side that's more severe, so if they rate one side as a 6 out of 10 vertigo and the other side as a 4, the positive is on the 6 out of 10. If they have apogeotropic, meaning the eyes are going up on both sides, then you're going to say they have cupulolithiasis, which means that it's adhered to the cupula. I don't know if we identified specifically on the things, but we can show you later. And that means that
Yeah.
I love this.
We almost-
I can do this in my sleep without. I can talk about this all day. But anyway, that means that the side with less severe symptoms is positive. Okay, so it's a little tricky in terms of diagnosis with that horizontal canal.
This is a nice kind of like cheat sheet though, in terms of once you've done the test and you're trying to figure out what it all means. This is a good summary of how to interpret that.
I know that like the textbook complaint with posterior canal is usually like laying down or getting my hair washed or turning my head. Is it similar for horizontal, or how would you pick up an individual?
Rolling, I mean, to me, even with the positional testing, you can kind of get faked out. So I don't want to get too far into the weeds, but I use that as kind of like, okay, well, I'm going to formulate an idea of, I think it's probably on the right side. I think it's probably posterior canal, but people are such poor historians in general, that and they're not like taking notes when this is happening usually, right? So I would say use that, but take it with a grain of salt.
So
But
the
yeah,
horizontal canals you've seen then, is it a lot like, it's when I lay down, it's turning, like, does it look really similar to BPPV?
Yeah.
It is, yeah, it's still
Okay.
BPPV in the horizontal canal, right? But
Okay.
it can look, horizontal canal stimulation can look a lot like posterior canal stimulation is what I'm saying. And so even if they say, hey, it's when I'm washing my hair, well, are you rotated one way when you're washing your hair? Or are you more straight back, right? So both of those could provocate either one.
Yeah, it's kind of rare that we do the movements in isolation of only one canal. So
Mhm.
most of the time when we're moving around in our space, we're at different angles and we could be stimulating more than one canal.
Mhm.
So actually,
And you can have
That's a good
things
segment.
in more than one canal, which is even more fun.
so this is one of my best friends and we were having dinner and she mentioned to me, oh my gosh, getting old, it's rough. Every time now that I like roll over in bed, I get super dizzy. I don't know why. And I was like, have I got the answer for you? I was like, I will trade you. If you let me record your eyeballs and use it in every future presentation I ever do, I will fix it for you. So she came in and I did the loaded Dix Hall Pike and the supine roll test with her. This is the supine roll test, so I'm testing for horizontal canal BPPV. You're gonna see a recording of both of her eyes. This is a normal test, so this is a negative result. She did not have horizontal canal BPPV. So I'm just showing you the normal, because you'll see that her eyes do move around, but none of this is nystagmus. All right, so I'm tilting her head and I'm looking at the video and I'm trying to see if I'm detecting any nystagmus. There's nothing there. This is a normal result. Then we're gonna look at the loaded Dix Hall Pike, and this was a positive test. So you're gonna see some nystagmus. I'll try to point it out. So right now she's loading. Nothing's happening yet. She's going back into extension now. And as soon as she
Keep
opens
your
her
eyes
eyes
open.
right here. That's the nystagmus.
And it was quick. Right, so this is why, so these are the goggles we use. They're infrared goggles. They have cameras in each eye so you can see and record, so you can run it back. Because you are likely to miss that in real time, right? Especially if that patient closes their eyes for a second, they could blink through it and you'll completely miss it. So
A lot of our
really
testing,
nice.
we're like, open your eyes, keep them open.
Which is not fun for the patient. When you
No.
feel vertigo, you want to close your eyes. So.
So that was a positive test. So the nice thing was, I was like, hey, look, I saw the nystagmus. Let's have you do this very specific maneuver. We're gonna float that crystal right back into place and you're gonna feel great. And now, every time I see her now, she's like, guess what? My crystals are aligned. I'm like, lovely. Let me know if they ever come out of alignment and we'll do it again. Okay, so treatment. So this is the modified Epley maneuver. This might be the one that you've heard of from a treatment perspective. So you're starting out in the same position as the Dix Hall Pike, and you're going into the same position as the Dix Hall Pike to start. So whatever side you detected the BPPV on, whatever side they had nystagmus, you're starting there in the same position that you had the positive test. You then have them turn their head, then they roll. It's really important that they keep their head turned so they're actually facing down to the mat at this point.
And go from extension to flexion. Yeah.
And then they're gonna sit up and then voila, the test is over.
So that was in
You're
light
having
speed.
them, you're having them hold in each position. We did not do that because we would be here all day if we did that with each of these videos. But they do need to hold in each of those positions for at least 30 seconds or until any sit-stims subside. So if they do start feeling dizzy in one of those positions, or you happen to notice some nystagmus, you're waiting until that ends, or at least 30 seconds, whichever is longer.
Sorry, another question. What do you make of the cases where you do the Dix Hall bike and there's zero nystagmus, but the patient's got the, like, oh my God, the room's spinning, I'm very dizzy? Do you go through with an epley?
That's a great question. So one, that's why the goggles are really, if you're doing it without goggles, then the best thing you can do is probably just treat the symptoms. If you roll it back and you're really not seeing anything and you're very clear, I would start to suspect it's not BPPV and that it could be something else. But definitely could do a treatment and then repeat the test and see if it improves. Because sometimes, so over time, if you stimulate that canal, patients can actually start to minimize their nystagmus because that's what causes the severity of the symptoms a lot of times. So they'll start to kind of flex out of that nystagmus, and so it will be less strong. And so sometimes you just treat on symptoms and see if it improves. And if it doesn't, then start to look at the rest of the big picture of what else you did in your evaluation and what else could be causing it. So yeah, that's a good question.
Okay,
I would
so,
also say that it might be a different canal. So this is where I was saying horizontal canal, even with testing, can be, you can get like a partial positive with the Dix Hall pike, but when you do the horizontal canal, it's very much a positive. So make sure you do all of the tests.
okay, so that was treatment for posterior canal BPPV canalithiasis on the right side, because we started out with a head turn to the
Did
right.
you get that?
It's a mouthful. Posterior
That's how you would
canal
document it.
BPPV canalithiasis on the right side. Now we're going to look at horizontal canal BPPV canalithiasis. This time we're treating the left side. In a moment, we're treating the left side. There we go. So the treatment's called the barbecue roll. And you're going to start with a head turn 45 degrees to the side that you're treating. The patient is then
60 in.
60. I think that was 45. The patient is then going to roll onto that side. Again, you're holding all of these 30 to 60 seconds or until symptoms subside. They're going to roll onto that side that you're treating. They're going to hold there again.
Is there a head in like a neutral position or is it?
Yeah, so again, the cervical rotation doesn't really matter. Sorry, who's asking? Okay. The cervical rotation doesn't really matter. It's the head position. So, but it's easier because with this treatment, you're going pretty much in a 360. So it's easier to just have them side lie, go prone, and then you can either, there's two options. You can either push back from there or continue and roll.
So they were on their side. They went back to prone or to supine. Then they're going to go to the other side now. The last step is they're going to end up in prone. And then like Will said, there's kind of getting them out of that position is just dependent on what is the most comfortable for them. So they can either, I don't know guys, I'm sorry. So they can either like prop themselves up on their elbows and push back up into like a kneeling position, or they can keep rolling and then sit up from their on their side, or keep rolling to supine and sit up from there.
So essentially the debris at this stage is moved all the way through the canal. In order to dump it back to where it needs to go, you need to get them upright. But from here, the treatment is, in terms of rolling, is done. So it doesn't matter if you have them roll one more time. So for her, she would potentially roll back onto this side and then sit up. Or if she were to push back into quadruped and then sit up. Yeah.
I just had a question more about an older patient, maybe having some BPPV after a car accident, and rolling isn't as easy for them. Is there another way of doing this, I guess, for them?
Yeah, so there are certainly, so we work in the neuro population, right? So we've had patients with BPPV who have spinal cord injuries, like cervical spinal cord injuries, right? So they like literally can't roll by themselves, right? So you're trying to basically figure out, okay, well, you can use wedges and support, you know, if we need to do max assist, whatever support, we can do that. With treatment, what I usually do for those patients is have them kind of, you can wedge about 45 on one side. And then I have them, when I'm having, I think that we demonstrated that, right? With the head, you mind if I do demo live? So if I'm holding the patient here for assessment, I would have them grab my arms here and then lie them back, because then I can kind of guide them back a little bit more. They're not having to do as much of that work. So you just have to kind of go with what you can, but I would say that's kind of an advanced level course. I would think about once you understand the basics, then you can kind of get into some of the weeds there. But yeah, that's definitely a good thought.
And the key to that is really that we care about the position of their canals in space more than their body. So if we can get them the canals in the right space by putting wedges or doing other positions with their body, as long as it accomplishes where their head needs to be, then we're in good shape. Okay, so this is going to be treatment for posterior canal BPPV cupulolithiasis on the right side. See if I can get the video to play. We sure do. Okay, so they're going to rotate their head 45 degrees to the opposite direction of the side being treated. They're then going to lie down on the side you are treating and hold that for 30 seconds to a minute. They're then going to quickly move to the other side, but the key is they have to keep their head in this same 45-degree rotation. So they're now going to be looking down at the mat. They're going to hold that for 2 minutes, and then they're going to sit back up. So because this is for cupulolithiasis, that means it's adhered to the cupula. It takes a little more time, and the movements have to be very rapid to try to dislodge it because it is stuck. It's not freely floating in the canals like the canalithiasis.
So what I will caveat all of this, there are a lot of maneuvers out there. These are the most common ones, right? So sometimes you have to use additional maneuvers so again, I don't want to take you guys too far down the weeds, but just know that these are some of the more common ones. If you see other ones out there, yes, there are different versions of certain things, but they're all trying to accomplish the same thing. Yeah.
Is it ever indicated to do a maneuver more than once?
Yes.
If symptoms are still there?
Absolutely.
How do you determine how many maneuvers you do and when you want to do multiple versus when you don't?
You retest, and if it's still there, you try it again.
Okay.
And patient
Tolerance.
yeah. So they might say, no, I'm never doing that again. Or they might say, yeah, let's go. I had a patient recently with a really complicated case that we were there for like 3 hours. It wasn't all maneuvers, but it was a long.
Our standard vestibular eval at our clinic, because we get kind of difficult cases, is 2 hours.
Yeah.
So
And that's not all maneuvers, but it's.
Yeah. Okay, so this one is very similar, but now we're treating anterior canal BPPV, cupulolithiasis, treatment for the right side. Anterior canal BPPV is pretty rare, but we're gonna go ahead and say maybe it could happen.
Well, especially this version
And
with this cupulolithiasis.
Here's the treatment.
Rotation toward the side.
Side.
We have audio this time. I don't know what's going on.
Right? Start with the rotation toward the side that you're treating. So
There
in
we
this
go.
case would be the right.
So
The patient is then going to
they're turning their
lie
head
down
this
to
time
the right
45
side.
degrees to
So
the
that
side
45
being
degree
treated rather than
rotation
away
is
from the side being
maintained.
treated.
The patient
They're gonna lie
holds
down
this
on the side they're
position for 30 to
treating.
60
Once again,
seconds.
hold that
And
30
then
to 60
after that 30 to 60
seconds.
seconds,
Then
quickly
they're
moves
going
to
to
the opposite
quickly move
side,
to the other
maintaining
side,
that
keeping
same
that head
rotation of the
turned,
head.
and now they're facing
And now
up.
the patient
They're
is
holding that 2
nose
minutes,
up
and then
at
they're
that
gonna
45
return
degree
to
angle
sitting.
and
to sitting
maintaining
up.
this
That's the end
position
of it.
for 2 minutes. After 2 minutes, the patient then sits back up. And this is the conclusion.
Okay.
So
Okay.
while we're stuck here, I like to think about this when I'm treating these, is the canal that's affected starts down. So if I'm thinking the anterior canal on the right, I'm going to turn my head to the right and put my anterior canal down. If that's helpful for you, great. If not, then ignore it. So it's just an easy kind of way to remember with these treatments, because it gets a little confusing with back and forth and right and left and up and down and rotation. 45 degrees rotation, 30 seconds, 60 seconds.
Yeah.
Anyway.
Okay, so
Go
this next one is for treatment for horizontal canal BPPV cupulolithiasis. It's going to show treatment for the right
Down onto their
side.
side, keeping their head in that position. They're going to hold this position for
Slightly
up to
narrowing.
2 minutes or 30 seconds beyond the conclusion of their symptoms, either vertigo or nystagmus. From there, you're going to have the patient remove the pillow if they're using one and rotate their head 45 degrees towards the mat, and then maintain this position for an additional 2 minutes. From here, the patient is going to sit up, look straight ahead, and that is the conclusion.
Pretty easy, right? You just lay down
Well
on your
said.
head.
Do you ever educate patients on doing this at home, or do you usually have them do it in the clinic?
I do if there's no other option. And the reason for that is it's hard enough for us to get the patient to do this accurately. The odds of them doing it accurately at home go down, right?
Right.
So if it's something where somebody is really far away or they're in a remote area, sometimes I'll get family members who call me and like, oh my gosh, I have this thing. So I have done that. You can do a lot of this virtually. And so I actually did a talk on this during COVID, because there's a lot of things you can kind of modify and do and walk people through. But I find that the success rate goes down in terms of assessing accurately and then treating accurately. So, but it's possible.
Thanks.
Okay, so, yeah,
Which canal did the last treatment?
horizontal, right horizontal canal.
Cupulolithiasis.
So, all right, so BPPV is the most common cause of dizziness, and that's fortunate because it's pretty easy to treat. Once we get the crystal back where it needs to be, it should resolve their dizziness. But now we're going to talk about other vestibular conditions, and unfortunately, those are more complicated and take more time to resolve than BPPV. So I'm going to give a caveat that we have several conditions to cover and
20
not
minutes.
several minutes. So we're going to move a little quickly, but you've got slides that summarize all of this.
And if you guys have questions after this, we're happy to
Yeah,
field
well,
those. If you
we're
have,
happy to
not
sit
just
around.
today, but if you have them beyond and you're out in the clinic and you have questions, email and call us. So
Okay. So vestibular neuritis, this is the second most common cause of vertigo after BPPV. And that said, it's not very common for someone who's in an acute phase of vestibular neuritis to present to a therapy clinic. The key symptoms we're looking for are listed here. The big one is that they have this sudden onset of severe prolonged vertigo that lasts at least a day. And they're going to experience rotational vertigo, which gets worse with head movement. They're going to have this spontaneous horizontal rotary nystagmus. It beats towards the unaffected ear when we're looking at it. They're going to have a postural imbalance, so they're going to feel very unsteady. They're going to tend to fall towards the affected side. They're usually, because of all this dizziness and spinning, they're going to have nausea accompanying that. And then when we do testing in the clinic, they're going to have a positive ipsilesional head impulse test. The solutions for this, the first one is we need to refer them to a physician to stabilize with medications typically. So it's a neuritis, right? That's an inflammation. They'll usually prescribe some vestibular suppressants for the first few days so that the patient can just tolerate the life while they're waiting for this inflammation to go down. So they usually rest for a few days until that most severe symptomology has faded a bit so that they can tolerate actually leaving the house and going somewhere for treatment. Vestibular rehab is going to take place after that acute phase, and it's going to consist of habituation exercises and gaze stabilization exercises. We're going to talk about what those are after we talk about each of the conditions, so we'll cover those. I give up. I'm just gonna.
So if
I'll
you guys
be
know what
here.
Bell's palsy is, this is very similar to that. It's just a different nerve, right? So it's just inflammation that hits that nerve.
Okay, next.
Yeah.
Vestibular migraine. So the International Headache Society has created a diagnostic criteria for vestibular migraine. And they say that to be considered a vestibular migraine, the vertigo needs to be fleeting, more than fleeting, lasting at least 5 minutes, which is a pretty significant amount of time to experience vertigo, but it has to resolve within 3 days.
So 5 minutes to 3 days.
The pain characteristic of migraines is present during at least 50% of episodes. So those are things like sensitivity to light and sound, kind of the typical migraine symptoms that are pain related have to be present at least half the time that they're dizzy. And then they need to have a current or previous history of migraines. What do we do about this? There's a few different avenues you can go down. The first is identifying triggers and avoiding them when possible. So helping the patient figure out what's actually triggering the migraine and maybe some lifestyle changes or some ways to avoid those triggers. Lifestyle changes to reduce the risk of a migraine. So those include an aerobic exercise program, stress reduction strategies, not smoking if they're a smoker, and then probably starting a food diary because oftentimes the triggers can be dietary. So if they can start linking their dietary choices to symptoms, then we can again help them avoid those. We want to treat the symptoms. So that's going to be habituation, gaze stabilization, and compensatory balance exercises. We'll get to those. And then if they're not already hooked up with neurology, which they might be because they should have a history of migraines, so they might have a neurologist. If they don't, or if this is something new that they haven't talked to their neurologist about, we want to get them back to see their neurologist.
I would add to that, obviously with cervical dysfunction, sometimes that can be a trigger for migraine as well. So treating any cervical dysfunction if they have.
Yeah.
Is there a certain referral pattern for vestibular migraines?
Meaning like a pain pattern?
Yeah.
Yeah, it's as variable as migraine in general. So sometimes like 50% of the time they may not have any pain. It may just be vertigo, which is kind of the confounding factor, right? It's like you're just getting these episodes of vertigo out of nowhere. But they have a history of migraine and they're lasting 5 minutes or longer and it's not neuritis. And so it's kind of, you have to start by excluding some other things a lot of times before you can kind of include the it's one of the more difficult diagnoses. Yeah.
Is this tied to like functional neurological disorders at all, or is it even like treatable? Is this something that like a psychologist might be indicated for?
Vestibular migraine? Not really. So really what you're trying to do is let the people know that the big difference is that you're like, okay, you still have migraine and this is a version of that migraine. And so we need to treat it like a migraine, right? The only difference in terms of our role in that is that you need to do some habituation to make sure that because the vestibular migraine is throwing off the calibration of your vestibular system in general. And so you'll see things like vestibular hypofunction or corrective saccades, or with vestibular migraine, you can actually get a lot of central signs, and which is very worrisome, but it's a migraine, it's not a tumor, right? So that's a good thing, right? And that's the cause, but it's widely variable in terms of what you're seeing at bedside. But the biggest thing is that they're treating the migraine, right? And then from our standpoint, we're treating the vestibular symptoms. So you treat what you find from a vestibular standpoint. If they have deficits in your evaluation, you treat those.
I would say there could be a role for psych if their symptoms are being triggered by stress and they need some help managing some anxiety that might be triggering it. But again, it's usually you're treating it like a standard migraine. So it'd only really be indicated if the stress is the trigger and they need some way to target that stress. All right, so Meniere's disease is fairly rare. It's a chronic condition where the person experiences repeated episodes of vertigo. They'll usually have tinnitus, hearing loss, and a sensation of pressure and fullness in the ear. And the symptoms will come and go in attacks with just gradual resolution of the symptoms after each attack. They'll also present with endolymphatic hydrops, which is excess fluid in the ear. And this is sort of like a chicken and egg situation where the research isn't really clear on whether the excess fluid causes the symptoms or whether it's just another symptom of Meniere's. They're still doing research on that. So treating someone with Meniere's, typically the first step is referred to ENT, ear, nose, and throat. And that's going to consist of things like medication management, dietary recommendations. They might get steroid injections in their ear, and they might actually go through a procedure where they ablate the vestibular end organ. So if that organ is no longer functioning, they can't be experiencing dizziness or vestibular abnormalities in the same sense that they were before.
Then they have a permanent vestibular hypofunction on one side, and we treat that.
Yeah.
It is then fixed, and then it's easier to treat.
Yeah, so it becomes then a stable condition that then we can work with. So vestibular rehab might occur between attacks, or if they've had that ablation of the vestibular end organ, they'll have a permanent loss of their vestibular function, and so then we can treat at that point as well. Again, habituation and gaze stabilization exercises are the go-to. Want to take this one?
Sure. Superior canal dehiscence, so this can happen technically in any canal, but most commonly it happens in that anterior, or also known as the superior canal. And it is basically that you have a defect in that canal where it is communicating. All those canals are bony structures. So there's some kind of perforation in that canal, and that allows, because we're transmitting sound and vibration through those structures, right, which is how we hear, you will actually have that transmission of vibration exit in more than one place. And so the result is that you'll actually hear internal sounds, right? So the hallmark is usually that you can hear your own heartbeat, or you just hear really loudly, you hear all of your head movement, swallowing, coughing, etc. You'll just hear those sounds very, very loudly. So we call it hyperacusis. Pulsatile tinnitus is that hearing of your heartbeat, hearing loss. So actually, if you do hearing testing, they're going to lose hearing from external sources because that hearing is less efficient because it's exiting in a different fashion. And vertigo, right? So the vertigo, the hallmark is that the vertigo comes on when they have some kind of really loud sound or vibration that happens externally, and then suddenly they get very dizzy, right? So somebody might tell you, hey, I went to a concert, and every time the volume got really loud, I was getting vertigo, right? So that's a pretty typical sign. This can be something that somebody is born with. It can be something that happens after an accident, so with head trauma, or it can just happen spontaneously because you're born. You can have just thinning of that area, and then one day it just happens. So typically we want to refer out, if they haven't already been referred from ENT, we want to refer them for further testing options. There are some surgical options if it's bad enough, and then they could go in and either plug or resurface that dehiscence. And then you should be seeing a pattern here. A lot of the treatment for anything that's not BPPV is going to be those habituation and gaze stabilization. It just depends. The variation is more in how you dose that and the types of exercises you're doing.
Okay, so central nervous system injury, this can mean a lot of things, but the indications are that when we're doing our assessment and our evaluation, we're seeing what we call central signs. So when we see these things, especially if we're seeing all of these things together, it's going to be indicative that something is happening within the central nervous system, rather than that peripheral component of the vestibular system, like we talked about earlier. So some of these central signs are that they have inaccurate saccades, they have corrective saccades with smooth pursuits, they might have primary or gaze evoked nystagmus, so that means primary would be they're just sitting looking straight ahead and they've got nystagmus going on. Atypical nystagmus or aberrant eye movements during BPPV testing. So you're doing your testing, your positional testing to either rule out or rule in BPPV, and their eyes are just doing something that doesn't follow the rules. And you're testing it and you're like, that doesn't track, that's not on my cheat sheet for how to interpret this. That's a central sign. And then a lack of VOR suppression. So we kind of hinted earlier, we mentioned earlier that a lot of patients coming in will come in with a central nervous system diagnosis of some kind. You know, they've had a brain injury or they've had something happen and we know about that. So then it's not surprising, and hopefully they're already seeing a neurologist and we're just confirming that that's the cause of their symptoms. But if they're coming in and they have no diagnosis at all and they don't have a neurologist, haven't been to one, then if we're seeing these signs, that's very concerning and we want to get them to a neurologist, if not the emergency room, if it's a evolving situation. So once we've established that we know they have a central nervous system injury, they're all stable, everything's good from a neurology standpoint, then we're treating what we find. So based on central nervous system could mean a lot of different things. So we're going to go through, see what symptoms they're having and address each of those. So that'll be, again, habituation exercises, gaze stabilization exercises, some balance training, some visual training as well, especially with this population, making sure that their visual system is accurate so that it's not giving them incorrect information about where they are in space. Yeah.
If you're treating a stroke patient who's in the chronic phase and they're like 5-10 years out of stroke and they get vertigo, could they still possibly test positive for those central signs, or how would you rule that out?
So they would definitely be able to test positive, right? So if they had an injury and those things weren't healed, they would test positive, right? You have to determine whether or not, like if this is new vertigo and that's right, is that what you're saying?
Yeah.
So is it BPPV, but they have central signs, right? So maybe they had kind of underlying vestibular deficits, but they weren't severe enough to cause like really significant symptoms to where they came in for that. But so they could have those central signs, but they wouldn't be necessarily the cause of their vertigo. And they certainly could have BPPV still. And in fact, that is the case a lot of times with head trauma, especially recent head trauma.
So stroke default is not, you know what, this person had a stroke, they're definitely going to test positive on at least one central sign.
Probably.
Oh, they probably will. Okay, so the
depending on where the stroke was, yeah.
Okay, so the expectation if you're treating somebody post-stroke is don't freak out if you see a central sign. Okay.
Correct.
Yeah, if they're coming in with a stroke diagnosis and that's a
Well, I mean
known
like 10
thing.
years out,
Yeah.
a lot of the time type thing.
But yeah, you would, so yeah, it's just like the fact that all of their other symptoms haven't resolved in 10 years, right? So if you had unilateral weakness, right, or and spasticity, all of those things are still persisting many years later, right? It's the same thing. All of that vestibular function may not be optimal.
I think to your point though, it could be a good idea then to do just some quick screenings for other signs that they might be having something more acute with stroke, you know, like doing your BFAST, the balance and face and everything, and just making sure there's nothing acutely happening that's causing this sudden trigger of new symptoms. So yeah, I think proceed with caution, right? It's hard to tell when someone's had a stroke. If someone's had a stroke, they're at risk for having another stroke. So you don't want to miss something new developing, but you also don't want to panic because they're showing signs that might be related to that first stroke. So it's just something you're going to have to do a little more of a kind of differential on to figure out where that's coming from and if it's something new. And I would say err on the side of caution. Like if you're not positive, have them go be checked out again.
Thank you.
Okay, cervicogenic dizziness. So this is when I mentioned earlier that we did the cervical joint position error testing, that sometimes you can have dizziness that's caused by a mismatch between where your body thinks your head is in space, right? What signals your neck is giving versus where it actually is. And if there's a mismatch there, you can have some dizziness. That's specifically called cervicogenic dizziness. So they're usually presenting with neck pain. A lot of times they have very limited cervical range of motion. They'll report headaches. They'll show an ataxic gait sometimes. They might have dizziness with head movements, and they will fail that cervical joint position error testing. Solutions, the first step is really manual therapy to address the neck dysfunction in the first place. So if they're having some sort of muscular imbalance or something that's causing those incorrect signals, we need to address that first. The next step is to do target training with that target from that we use with the laser. So we can do training with that. We then want to move on to habituation exercises, especially functional movements and head turns. And then we'll work on balance training as well. Vestibular hypofunction and VOR dysfunction. With this one,
Talked
they're
a lot about this, so we can blitz through.
very brief. They'll report dizziness. Especially the interesting one with this is that they'll report dizziness when they're looking at complex visual scenes. So if something is really crowded or visually busy, that can actually cause dizziness. So that's kind of interesting. They'll show a VOR deficit with testing, and they might have some outside diagnostic testing that is showing a hypofunction as well. So they might come to you with that report. For this, again, gait stabilization exercises, and then we might also look at habituation exercises and balance exercises, depending on kind of what's going on with them and if those seem like they're indicated. All right, so now getting into all these exercises in like 30 seconds. Habituation exercises, we're gonna identify movements that cause moderate symptoms. And we're gonna have the patient do those movements until the symptoms reach usually a 2 to 4 out of 10 on a severity scale for up to 1 minute. So they have to have some symptoms to get the benefit. We have a patient right now who calls it like sweet and sour, where like, she's like, you have to have a little sour to have the sweet, like meaning that she'll get some benefit out of it. And it totally works for her. We're like, go do this exercise till you hit the sour, and she like gets it. So it totally works. So they do have to have some symptoms or it's not doing anything. So it's going to be uncomfortable for them.
People love us.
Yeah, they're big fans of us. Gait stabilization exercises. We have these cards. They have some sort of design, in this case our logo, with a letter in the middle. We use an E because it's very clear looking at the E whether you can see it precisely or whether it's getting distorted in some sort of way or blurred.
E on, and the patient is going to look at the E
This one as well.
and move that card from side to side while keeping her head still. This can
I want to
also
try to
be done
minimize this. It's very
by moving
difficult
the card up and down.
Try to minimize. Again, the goal is 2
Can
hertz.
also be done by
Right, so that's
keeping
the
the
rate at
card
which
still
our
and
VOR should
moving
function.
her head. So the card stays still and the head moves from side to side, or the head moves up and down. Additionally, these can be done.
So we would progress that further by having them do it in standing, or having them do it while walking, or having them move both the card and their head in opposite directions. We're going to progress that further, and until they're able to do it at that rate of 2 hertz without a big spike in symptoms, and hopefully then they're reporting some functional improvements as well. We made it.
1 minute over.
1 minute over. All right, sorry for the tech issues, guys. I don't know what happened there, but this is our contact info. You've got it on your slides. Feel free to email us or call us, or those are our direct lines. You can even text us. If you've got questions on this stuff, we're always happy to nerd out on it. We could go on and on about all of this. So I know it was a really fast introduction and we had to go through concepts really quickly, but we're happy to chat more. All right, questions? Oh, and there's a reference slide at the end if you want to nerd it out and go look at any of the sources.